Welcome back to Student to Stud. In this episode, we'll go over periprosthetic fractures around total hip arthroplasties. This is an advanced topic, but will give you everything you should know as a medical student. Here's the basic outline on what we'll cover in this presentation. Time for the first case. How would you read these x-rays? We have three views, AP pelvis, AP right hip, and cross-table lateral of the right hip, demonstrating a right periprosthetic fracture with femoral stem subsidence. This fracture was treated with a revision of the femoral stem with 3 cerclage cables. Periprosthetic fractures are a major expense to the healthcare system, and the incidence continues to rise with the increase in joint replacement surgery in the United States. We will discuss the incidence of periprosthetic fractures, but I want you to understand the concepts and not necessarily the numbers. Periprosthetic fractures in primary cemented hips occur 0.3% of the time. This incidence is higher in uncemented hips at 5.4%. Revision surgery even carries a higher risk of fracture, with cemented hips occurring 3.6% of the time and uncemented hips occurring 20.9% of the time. I want you to take home from this slide that cemented hips have a lower risk of periprosthetic fractures than uncemented hips. The average time for primary total hip arthroplasty to fracture is 7.4 years. The number is decreased with revision surgery to 3.9 years. This information highlights the increased risk of fractures with revision surgery. The 1-year mortality is 11%. We will soon go over the Vancouver classification, but I want you to know that there's a higher mortality rate with ORIF than revision arthroplasty in Vancouver B fractures. These fractures can occur intraoperatively and postoperatively. The postoperative fractures are most commonly due to a fall. There are several risk factors that increase the risk of sustaining a fracture. Osteolysis can loosen the implant. If there's impaired bone quality, such as the patient having rheumatoid arthritis, Paget's disease, osteoporosis, if the patient's on chronic steroids, if they have a tumor, or if there's trauma. Uncemented implants and revision surgery, like we previously discussed on the last slide. Females are at a higher risk. Age is a risk factor. With the older you are, the higher the likelihood of sustaining a periprosthetic femur fracture. And the higher your BMI is, are all risk factors. When obtaining your history, you want to ask if they had any prior thigh or groin pain. You want to find out if they had any startup pain or any complications after the original surgery, such as delayed wound healing or drainage. Your physical exam will likely demonstrate tenderness at the fracture site, inability to ambulate, pain with any range of motion. It's a good idea to look at the previous surgical incision to determine which approach was likely used and if there's any concerning features. And like always, you want to do a good neurovascular exam. Your workup will consist of obtaining the prior operative report to find out what implants were used and if there were any unusual intraoperative events. In addition, you always want to think about infection and if this patient could possibly have an infection. If you are concerned, you will order a BMP, an ESR, CRP, and joint aspiration. You will order your standard radiographs of the pelvis, hip, and femur. You may need to order a CT scan to further define the fracture. Radiographically, there are several features that you will need to evaluate for that may indicate loosening. Lucency at the cement bone cement stem interface, if there's the cement mantle that's fractured, if there's a pedestal sign. Do you know what the pedestal sign is? This is when there's new bone formation below the cementless femoral stem. If you see local cortical hypertrophy, that can imply loosening, as the stress is being transferred away from the porous-coated metaphyseal femoral implant. Next, you want to compare with prior radiographs. Are there any changes to the stem, the acetabulum, or the polyethylene liner? Has the femoral stem subsided? Is the femoral head asymmetrically located in the acetabulum, indicating polyethylene wear? Are there any gross changes to the position of the implants? Lastly, if you see proximal bony overgrowth. All of these can be radiographic findings that can suggest loosening. The best thing to do is to always compare prior x-rays to the current films. Intraoperative fractures of the acetabulum do occur. Some risk factors are if you under-ream greater than 2 millimeters, if the patient has impaired bone quality, if you use a cementless acetabulum component, if the hip is dysplastic, or if you're using an elliptical modular cup. If you determine there is a fracture, you must evaluate the stability. If the acetabulum is stable, you do not need to do anything, and you can think about protecting their weight bearing, but this is definitely a controversial subject. If you determine the cup to be unstable, then you can perform any of the treatment options listed below. You can exchange the cup, you can add additional screws, you can perform open reduction internal fixation, you can use bone graft, and you can protect their weight bearing. We won't dive into these treatment options anymore as these decisions are complex. I encourage you to read about this topic, but you won't be expected to know why you would perform one of these treatments over the other. Like the acetabulum, intraoperative femur fractures do occur. When they occur, you can hear an audible crack or there will be a sudden change in the resistance. Like one of my mentors has said, if you aren't breaking a few femurs in your career, then you aren't putting them in tight enough. There's an intraoperative Vancouver classification for femur fractures in which the fracture is broken down into A, B, and C. A is a fracture of the proximal metaphysis, B is a fracture at the diaphysis, and C is a fracture distal to the stem. These are further broken down into 1, 2, and 3. 1 is a perforation of the cortical bone, 2 is a non-displaced crack, and 3 is a displaced fracture or unstable fracture. There are several treatment options. Likely you will remove the stem, use cerclage cables, and reinsert the same stem or implant a larger stem. You can use plates and screws or a combination of both. I encourage you to read about this topic as each subtype has their preferred treatment option. One take-home point from this slide is that if you have a fracture distal to the current femoral stem, you must place a revision stem that bypasses the fracture by at least 2 cortical diameters. The post-operative Vancouver classification will be what we spend most of our time on. This classification is used to guide treatment for these injuries. The Vancouver classification takes into account 3 characteristics: the location of the fracture, the stability of the implant, and the quality of the bone. This classification is broken down into A, B, and C with several subtypes. Here is a summary of the classification system. We will dive into each type and what the preferred treatment options are. Vancouver A fractures are broken down into 2 subtypes: fractures around the greater trochanter or fractures around the lesser trochanter. Fractures of the greater trochanter displaced less than 2 centimeters are treated with protected weight bearing with no active hip abduction. Fractures of the greater trochanter displaced greater than 2 centimeters, or if there's osteolysis, are best treated with a hook plate or cerclage cable with or without bone graft. There was a study that was performed that demonstrated that patients who had a fracture of the greater trochanter displaced greater than 2 centimeters had persistent pain and had a limp at 1 year. Here is a radiograph of the right hip that demonstrates a non-displaced greater trochanter fracture that was treated with toe-touch weight bearing and no active hip abduction. If the fracture is at the lesser trochanter and is stable, it does not require surgery. If the medial cortex is displaced, or if there's a loss of the medial buttress, then surgery is required with cerclage cables with or without revision of the femoral implant. Vancouver B1 is when there's a fracture at or just below the stem, but the implant is still stable. If there is minimal displacement, you can think about treating these fractures without surgery. Most of these fractures will require surgical intervention with a plate and screw and cerclage cables with or without bone graft. You want to try to get bicortical screws proximally posterior to the cement mantle if the implant was cemented, and place cerclage cables proximally and screws distally. Here is a case that demonstrates a B1 fracture. This fracture was treated with a plate with cerclage cables proximally with screws distally. B2 fractures are when there is a fracture at or just below the stem and the implant is unstable. The preferred treatment is to use a long diaphyseal engaging femoral stem with cerclage cables and possibly revise the acetabulum. Remember that you want to place your femoral stem that bypasses the fracture site by at least 2 cortical diameters. Here is a case of a B2 fracture. You can clearly see that the femoral stem has subsided and is unstable. It was treated with a revision stem and 3 cerclage cables. You want to use a cementless stem, as if you used a cemented stem, the cement can extrude into the fracture site and lead to a non-union. B3 fractures are when the fracture is at or just below the stem with an unstable implant and poor bone stock. Young patients, you will try to convert their femoral stem to a long diaphyseal engaging stem with bone graft with or without an allograft. Elderly patients, you will likely convert them to a proximal femoral replacement. Here is an example of a patient who sustained a B3 fracture. This patient was treated with a proximal femoral replacement. Vancouver C fractures are when there is a fracture well below the femoral stem. If there is good bone stock, you will treat these fractures with open reduction internal fixation, but if there is poor bone stock, you can use an allograft. Here is an example of a patient who sustained a C fracture. This fracture was treated with 2 plates, cerclage cables, and screws. There are several complications that can occur when dealing with these types of injuries: non-unions, refracturing, aseptic loosening, instability, which can lead to dislocation. On the right, you can see a dislocated total hip arthroplasty. You can have deep infections, and you can have a failure of the implants. Let's move on to some Pimp questions to finish off this difficult topic. Question 1. What is the preferred treatment for a Vancouver AGT with displacement less than 2 centimeters? Protected weight bearing with no active hip abduction. What is the preferred treatment for a Vancouver C? Open reduction internal fixation with cerclage cables with or without bone graft. Question 3. What is the treatment for a Vancouver B3 in an elderly patient? Proximal femoral replacement. Question 4. What is the treatment for Vancouver B2? Long revision stem with or without open reduction internal fixation. Question 5. What do you call a fracture between a total hip arthroplasty and a total knee arthroplasty? This is considered an interprosthetic fracture. Question 6. What is the preferred treatment for a Vancouver B3 in a young patient? The preferred treatment is to use a diaphyseal engaging femoral stem with bone graft with or without an allograft. What is the preferred treatment for a fracture of the greater trochanter that's displaced greater than 2 centimeters? This would be treated with cerclage cables or a trochanteric claw plate. Question 8. What is the preferred revision stem for a B2, cemented or uncemented? Uncemented. Remember that if cement is used, it may enter the fracture site, leading to a non-union. Question 9. What are some risk factors for intraoperative periprosthetic fractures? Minimally invasive surgical techniques, press fit, cementless stems, females, revision surgery, and impaired bone quality. Question 10. Press fit femoral stems create what kind of stress on the femur? Hoop stresses. Question 11. How many cortices should the diaphyseal revision femoral stem bypass the fracture site in a Vancouver B2? Greater than 2 cortical diameters. And that's all for periprosthetic fractures around a total hip. Until next time, thank you for listening, and hopefully that was helpful. Be sure to give us a thumbs up or leave us a comment so we can better serve you.